Assalamu alaikum. I am Dr. Mahajabin Meman, consultant neurosurgeon at the Department of Neurosurgery, LUMS, LUH, Hyderabad. Today we'll briefly overview vestibular schwannoma. It's a very important topic in long cases especially, but it can be in short case or talk station as well. Vestibular schwannomas, if there is a long case, the first question an examiner asks after history and examination is that what could be the differential diagnosis if the lesion is in CP angle. The three most common differentials are vestibular schwannomas, meningioma, and ectodermal inclusion tumors, which includes the epidermoid and the dermoid. These are the three most common differentials and should be told first. These all differentials are least common and you can put them on fourth or fifth, but the three most important differentials, these are vestibular schwannoma, meningioma, and epidermoid, and it should not be missed at any cost. The histopathology of vestibular schwannoma shows compact elongated cells which form Antony A fibers and loose reticulated cell arrangement that forms Antony B. There are also eosinophilic bodies which are formed by the parallel arrangement of spindle-shaped Schwann cells, and they are known as the Wernicke bodies. The clinical features of vestibular schwannoma presents as classic triad of ipsilateral sensorineural hearing loss, tinnitus, and balance difficulties. There can be other features as well, but this is the classical triad, and the most common symptom is this ipsilateral sensorineural hearing loss. Previously, it was thought that the hearing loss is due to compression or stretching of the eighth nerve, but the recent evidence suggests that there are possible toxins that are released from the tumor and they cause cochlear damage, resulting in the sensorineural hearing loss. An also interesting fact, another, is that though the facial nerve is distorted early and the facial nerve is very near, obviously, bulky it is with the eighth nerve, facial nerve is involved later. But trigeminal nerve, though it is far away, it is involved first because the motor fibers, that is the facial nerve, they are resilient relatively as compared to the sensory fibers of the trigeminal nerve. So paradoxically, instead of the seventh nerve involvement early, there is involvement of the trigeminal nerve in the disease. Now we know that in Rene's test, the air conduction still will be better than the bone conduction, that is, the Rene's test will be normal, which is otherwise called positive. But the Weber's test will lateralize to the normal side because the Weber's test will will prove that wherever the bone conduction is better than air conduction, in, for example, sensorineural hearing loss, the Weber test will lateralize to the normal side. The clinical grading of facial nerve involvement is divided on the basis of House and Blackman classification. The most important demarcation is from the grade 4 because after grade 4, the eye closure becomes incomplete. So in grade 1, 2, and 3, which is mild, normal, mild, and moderate dysfunction, still the eyes can be closed. But after grade 4, the eyes completely do not close, and this is how you can roughly tell a patient's House and Beckman grade based on just this single finding. There are very important features which distinguish the vestibular schwannoma from CP-angle meningioma. Obviously, we know hearing loss is first to go in vestibular schwannoma but late in CP-angle meningioma. We already discussed that the facial nerve and trigeminal nerve, they are usually late and usually not present in vestibular schwannomas, but in CP-angle meningiomas, these two nerves are more commonly affected. MRI findings, we know that in vestibular schwannoma there is heterogeneous signal enhancement, but CP-angle meningioma or even any meningioma will show homogeneous enhancement. Internal auditory canal, as the tumor arises from the internal auditory canal, then the tumor shows an enlarged internal auditory canal, whereas the CP-angle meningioma shows a normal or narrowed canal. Calcifications are obviously more common in meningiomas, and the angle between the tumor and the petrous bone, here is the acute and here is the obtuse angle. Now, if we talk about workup, you have to say that there are three sets of studies. Number one are the radiological studies, which include the CT, MRI, and uh, Fiesta if available. The second are the audiometric studies, and the third, if you go for surgical planning, then you go for thin cuts temporal CT. On the basis of these imaging, the vestibular schwannomas can be divided into four grades on the basis of Coe's grading. Now, if the tumor is in the canal, it's grade 1. If it goes into the sapiengal cistern but it's not approaching the brainstem, it's grade 2. If it is approaching the brainstem but is not displacing it, it is grade 3. And if it is displacing the brainstem and compressing the fourth ventricle, it's grade 4. This is how you identify the approximate volume of the tumor as well. The audiometric studies, they include pure tone audiometry, speech discrimination tests, and the tumors which are less than 1.5 centimeters, you do three more tests, that is the ENG, which assesses the superior vestibular nerve, VMP, which assesses inferior vestibular nerve, and ABR, which is used for prognostication. It is easy to remember that E comes before V, so superior vestibular nerve will be checked by ENG and inferior vestibular nerve will be checked by VMP. On the basis of this, we divide the hearing into serviceable and non-serviceable hearing. There are two grading systems, Gardner-Robertson and AOHNS grading system. So just to understand simply, the serviceable hearing is defined by the 50-50 rule and the 70-30 rule. That is the Gardner-Robertson class 1 or 2 or AOHNS class A or B. If 50-50 means the patient can hear 50% of the speech, more than 50%, and hearing can hear PTA, can hear sound less than 50 decibel, or 70% word recognition score or 30 decibel PTA. So this is how we define serviceable hearing. Now, after diagnosis, there are four management options. They can be expected management, surgery, radiosurgery, or chemotherapy. Expected management is done for in small lesions, but if there is a rapid growth, for example more than 10 per year, then you go for surgery. There are multiple options we'll discuss shortly. For radiotherapy, we have beam radiotherapy, stereotactic radiosurgery, in which the total dose is 13 gray for the tumor and less than 4 gray for cochlea. That's a very important term. And stereotactic radiotherapy, in which the same radiation is given but in 4 to 5 sessions. Chemotherapy may, the one agent that is seen to be effective in this tumor is bevacizumab, that is Avastin. It is an anti-VEGF antibody, and this drug is also used not just here but for recurrent GBM as well. So this is an algorithm. There can be either of the four situations. In situation 1, the tumor is less than 1.5 centimeter and the hearing is normal. Then obviously you'll go for observation with serial imaging as well as audiometry. Another scenario in which the size is less than 1.5 centimeter but the serviceable hearing is present, then there are multiple options. It depends on patient's decision mostly, but you can observe, you can go for surgery or even stereotactic radiosurgery. Another situation can be that if the size is 1.5 to 2.5 centimeter, then if the patient is young, you go for surgery. If the patient is old, you can offer conservative treatment or stereotactic. If the size is more than 2.5, then obviously it's an indication for surgery. There are multiple surgical approaches. The three most common that we use are retrosigmoid approach, and that's the most important part of this approach is that it is versatile and preserves hearing. Translabyrinthine approach, it is not obviously it does not spares the hearing, it sacrifices it. And the middle fossa approach. So the choice of approach depends upon whether the hearing is salvageable or non-salvageable. If it is salvageable and if the tumor is extensive, like whose grade 2, 3 and 4, you go for retrosigmoid. If the serviceable hearing is present but the tumor is small in the internal canal, you can go for middle fossa approach. If there is non-salvageable hearing, there is complete hearing loss, you can go for translab. The most important thing is to remember that the facial nerve is pushed forward by the tumor in around 75% of cases. So this is why you should always do facial nerve monitoring, intraoperative as well as postoperative. Let's discuss about the middle fossa approach first. The indications are if the patient has preserved hearing, laterally placed tumor within the intracanalicular part, especially in the intracanalicular tumors, The pros are that it allows drilling and exposure of the internal aortic canal all the way up to the geniculate ganglion, and it's an extradural approach. The cons obviously are that it has a risk of damage to the temporal lobe and a risk of seizures. Its simple summary: you put in a lumbar drain, you give a straight incision in front of the tragus, starting from the tragus 6 centimeters the fillet, you dissect the temporalis muscle, do a craniotomy 4 by 3 centimeter, elevate the middle dura fossa and identify all these structures which are shown: middle meningeal artery, GSPN, V3. Then drill and expose the enteroaortic canal all the way up to the Bill's bar. Localize the facial nerve with the stimulator. Open the enteroaortic canal dura and then identify these vestibulocochlear and facial nerves and dissect the tumor of the nerves. The translab approach sacrifices hearing. It obviously takes longer time, but and also it has a higher risk of CSF leak postoperatively. But the advantages are it obviously identifies a seventh nerve earlier and it has a high preservation chance of the facial nerve. There is less risk of cerebellum and lower cranial nerves, and the patient does not get ill in blood and cisterna magna, especially, which is seen in retrosigmoid or other transcranial approaches. The summary is: the position of the patient is supine with head rotated to the contralateral side. Prep the abdomen, obviously, because there is a higher risk of CSF leak, so almost always prepare the abdomen for fat graft. Skin incision can be tailored to the location of the retrosigmoid, that is a sigmoid sinus, where it's mostly given just behind the ear like this. It doesn't require a craniotomy. The dural opening along the intra-aortic canal identification of seventh nerve. Again, with the stimulator for larger tumors, you can section the superior petrosal sinus for adequate exposure. And obviously, it requires a fat graft. Retrosigmoid approach: pros: most familiar, workhorse approach, quick access to the tumor, hearing preservation is possible. The cons are only few. Cerebral retraction can be a problem, but if you open the cisterna magna or the CP cistern, it can be very easy. And post-op headaches, they are very common because of suboccipital muscle work. The technique is simple. You position the patient in lateral decubitus position or in the park bench position with the tumor side up, and percutaneous lumbar drain can be optional. Other options can be a phrasial hole with an EVT placement, opening of the cisterna magna or CP angle cistern, or even preoperatively VP shunt if the patient develops with acute sign and symptoms of hydrocephalus. Incision is shaped like the pinna, three finger breadths behind the extra-aortic canal. The craniotomy has to be lateral enough to expose a part of the part of the sigmoid and part of the transverse sinuses. And to prevent the CSF leak, seal all bone wedges with bone wax. Dural opening can be done along the lines of the craniotomy. Exposure is enhanced by opening the CP angle cistern and the cisterna magna and draining 20 to 40 ml CSF. The petrosal frame can often be sacrificed because it comes in the way of the surgical field, and can also, because it drains to the transverse sinus, it can cause tearing of the transverse sinus. So it can be sacrificed in most of the cases. There can be post-op CSF leak, and it can be through the wound, otorrhea or rhinorrhea, but most leaks are diagnosed within 1 week of surgery and they usually resolve. One third of the cases resolve. Meningitis can occur in 5 to 25% of cases. Hydro may promote formation of a CSF fistula. There are multiple routes. They can be through the tympanic cavity, eustachian tube, horizontal semicircular canal, vestibule or posterior semicircular canal, perilabyrinthine cells, or even the mastoidea cells. The treatment, most of the cases, one third resolve spontaneously. A few non-surgical measures like elevating head of braid and lumbar drain can be used. Surgical treatment is for persistent leaks. If you did a translab approach, you can pack and permanently close the eustachian tube by a transtympanic membrane approach. If the hearing is preserved, then you should spare eustachian tube at any cost. So, what you do, you explore the surgical field, you revax the air cells, put in additional fat graft, fascia, pericardium, or any other sealant. And if there is hydrocephalus that is causing a CSF fistula, go for shunting. Surgical morbidity and mortality: that the most common complication is CSF leak, which is complicated into meningitis in just 5 to 7%, stroke in 0.7% cases by ICA or PICA involvement. There is subsequent need of shunt in 6.5%, and mortality rate is 1%. The cranial nerve dysfunction can be seen if the tumor is large. The larger the tumor, the more involvement of seventh nerve and eighth nerve. Thank you.